Okay, so you already got us. We're 7:59, so we're about ready to start. Okay, good morning, everyone. Welcome to the Ellis Medicine Grand Rounds. This is Dr. Carolyn Jones-Assini, Chair of Internal Medicine. And I want to remind you that this program is being recorded. And if you are on a phone line, please mute your phone. Emily will mute all the webinar participants. Now, the way for you to obtain your CME credits is for you to, after the program, complete an evaluation at the elliscme.org website. And if you choose to have the ABIM MOC points, please contact Amy Semerad and she will help you with that paperwork. I want to tell you a little bit about future Grand Rounds. Next week, we look forward to hearing Dr. Yap present to us on adolescent musculoskeletal spine issues. March 12th, Dr. Rebecca Seberth, a new ophthalmologist in our community, will be giving us an update for primary care in ophthalmologic issues. March 19th, at this time, we're planning a journal club so keep tuned in. We're not quite sure about that may be a different program, but at this point, we're thinking journal club. And March 26th, Dr. Cunningham will be tackling pain to the mat, managing pain in patients with medication-assisted treatment. So, this morning, we want to be sure that you know that as far as questions go, we'll leave all the questions to the end. Place your questions in the chat box if you're on the webinar. And if you're on the phone and have questions, unmute yourself and ask a question. And then immediately remute yourself would be best. Very good. Okay, so our speaker today, Dr. Robert Dachs, is Vice Chair, Department of Emergency Medicine at Ellis Medicine, and he is a Clinical Associate Professor of our Family Medical Residency and at Albany Medical College. He is an author and speaker on the national stage for many different CME type programs. So we welcome Dr. Dachs.
Great. All right, thank you, Carolyn. Let me share my screen now, so bear with me. Oops, here's the share. Here we go. Share the screen. Give me a second. Hopefully everybody can see that.
Yep.
We got it. All right. So, yeah, my topic today is COVID-19, the virology, vaccines, and variants. I have no financial conflicts of interest. I will make one disclosure before I get started, and that is I am not a virologist. I am not even an infectious disease expert. As Karen said, I'm an ER doctor. But for this talk, I've tried to do a deep dive into the literature and hit a number of reliable resources, such as these folks. For those of you who have not yet tuned in, if you have an interest in this topic, to This Week in Virology, also known as TWIV TV, an awesome resource. You know, if you want to sit around on a Friday night and have a couple of beers with your friends, TWIV TV is where it's at. What can I say? The other resources, you recognize some of these. Another good resource is View Medi, which has not only videos and updates regarding COVID, but any medical topics you might be interested in. All right, enough of that. I want to do this fairly quickly. I have a lot of slides, but I'm going to try to do this fairly quickly because I know people are going to have questions at the end, and we'll try to get to those. But the way I wanted to set up this talk was to sort of give a lay of the land of where the new genetic vaccines that have come along for coronavirus is where that is in the lay of the land compared to all the traditional vaccines we have. As we all know, vaccines all are designed to do essentially the same thing. That is, present us with an antigen, have us make our own antibodies. So the next time that antigen comes along, we have the antibodies to fight the disease. And vaccines come in a number of different shapes and varieties. This is the common breakdown. And, you know, the very first vaccine that we often consider in modern medicine was the smallpox vaccine, in which I think many of us know the story of Edward Jenner, who recognized that the milkmaids who got cowpox were not getting smallpox. So he took the pus from the arm of a infected milkmaid with cowpox and injected that into his gardener's 8-year-old son. And then what he did, which was different than what other researchers at the time were doing, is that he then took that 8-year-old child and exposed him to smallpox. And then he didn't develop smallpox. He then replicated this in some 20-odd other, quote, volunteers. And he got the same results. So you take a similar but less virulent form of the virus. Moving ahead in history real quickly is that you, instead of taking a similar virus, you take a weakened live virus. And this is what Albert Sabin did with the oral polio vaccine. And this is what we still do to this day with MMR vaccines and chickenpox virus vaccines. Other option is actually just kill the virus, but it still presents the protein to our body to make antibodies. And that's what Jonas Salk did with his version of the polio vaccine. And it's actually, this is still the strategy being used in 2 of the Chinese developed vaccines for the coronavirus, as I've got listed here. So this is still a potential avenue for vaccine development against coronavirus. Other ways to do it is to take a subunit of the virus, in other words, part of its protein or polysaccharide complex, like we do in Pneumovax, and present that to the body, create antibodies. And that's what the company Novavax is doing. And then we also have recombinant DNA vaccines that we're familiar with, the Hep B and HPV vaccines. And then just to put this all into perspective, this is in the last 50 years, we've developed and approved 44 different vaccines. We may not recognize it, but there's been 44 different vaccines in the last 50 years that have been approved that all fit into one of these categories, either the native protein and a polysaccharide, the live attenuated or killed vaccines, or the recombinants. So that's what we've been doing up to now. And now what we have is the genetically engineered vaccines, the mRNA and DNA vaccines that we're hearing all about that have been created for the coronavirus. I know most of you on this call are probably savvy to this, but for those of you not, I want to bring everyone along so we're all up to the same speed. As you know, this is the artist rendition of the coronavirus and a spike protein that attaches to your ACE2 receptor, and then you get sick. The way you get sick is that the coronavirus sort of hijacks your ribosomes and your cytoplasms, hijacks those ribosomes to create more viral single strand of mRNA, single strand of RNA, which is what the coronavirus is, and boom, pops out more organisms. In response to that, we make antibodies, and that's the natural course. So how do we get to the point where we just have those antibodies hanging around, ready to roll? And this is what the Moderna and Pfizer folks did. Very early on in this outbreak, I heard it was January, then I heard one report March, but I think it was January of this year, we got the entire genome sequence of the coronavirus very early on, all 30,000 plus amino acids. And in that 30,000 amino acid genome, there is the 1,273 amino acids that code for the spike protein. So what the researchers at Pfizer / BioNTech and Moderna did is they were able to just make that same 1,273 amino acid chain. And they said, well, now how do we get that into cells? And what they did, you probably heard, they made this lipid nanoparticles that surrounded the amino acid chain. And that is what gets injected into you. And that's the vaccine. Now, that those lipid nanoparticles is what sort of is forced the companies into keeping them in very, very, very cold conditions. You probably heard over the last week that Pfizer said, listen, we're going to go back to the FDA because we found that we don't need the deep, deep, deep freeze at negative 70 degrees Celsius. We just have to do a freeze. And they're going to go back, and that may freeze up some availability for the Pfizer vaccine in the future. Moving on from there, though, what happens is that mRNA now is in our muscle cells and our other cells, and it hijacks the ribosomes, and it makes just spike protein. Voila, we make antibodies, and now if we are unfortunate to come in contact with the coronavirus, ideally, we have those antibodies ready to bind up those spike proteins so they don't bind to the ACE2 inhibitor. That's the schematic. All right. Pfizer came along and actually made two versions initially of their vaccine, the B1 and the B2. And they did safety trials with it first. That's what they had to do. And these are the safety trials that were published in the journal. And the top line was the B1 and the bottom line was the B2. And you can sort of get a sense that the B2 caused less side effects, so they went with the B2. That's now the Pfizer vaccine that we're all using. And then they put it to the phase 3 trial, and this is the phase 3 trial, 40,000 people. You probably all heard about this. Vaccine versus placebo. They watched the patients for 60 days after the second dose, and they found a 95% efficacy. All right. Moved on to the Moderna, that was 30,000, and what you see almost very, very similar results, 94% efficacy. You'll notice the big news also, however, was that there was very, very little to no severe illness or death in the vaccine groups. And you may have seen these graphs that look just wonderful. How the vaccine, this is the Moderna vaccine, over time, over the 2 months, had very, very little illness or disease versus placebo. All right. As I noted, this was a 60-day follow-up, and what it did not address in these studies was asymptomatic carriage or transmission potential. We'll talk a little bit more about that later. Everybody loves to talk about the side effects. I will mention these briefly so that we all understand a little bit more about the side effects. This was the side effects in the phase 3 trials. And what you see up top is the younger age group, and the bottom slide is part of the slide is the older age group, age over 55. And in general, this is a broad sweeping generalization. I understand that, broad sweeping generalization, that the older individuals in general have a little less associated side effects than the younger volunteers in this study. The other thing I like to point out also, which is interesting, and this happens in many, many drug trials, is what is known as the nocebo effect. So if you look at things that are objective, like fever, for example, diarrhea is pretty objective. Those are objective measures. The placebo groups, for example, fever is 0, 0, 0. But when you get to the subjective side effects, such as fatigue and some headache, it's very, very interesting that a quarter of the individuals, especially in the young group, who got placebo complained about fatigue and headache. So this does point out that there is some nocebo effect, and we will see that also, I'm sure, when it comes time to our patients and ourselves and our patients getting the vaccine. Moderna had the same thing, almost the same exact profile, so I'm not going to spend much time there. One of the side effects that the public is very, very worried about, and people are worried about, is the anaphylactic reactions. The numbers I've got here, you can see Pfizer, Moderna, somewhere between 2 to 11 cases per million. And on the scale of things, that's pretty small. But I must have been, initially I was a bit dismissive of this, until I realized that when you look at all vaccines in general, that big number I showed you at the beginning, the amount of anaphylaxis to vaccines in general is only about 1 in a million. So there's perhaps a very slight little uptick chance of anaphylaxis with these vaccines compared to all our other traditional vaccines. Last week, the New England Journal had a very nice article on why this might be. And one of the things they're pointing out, and I point out here, and they highlighted, is that they think it might be one of the excipients, which is polyethylene glycol. They're not sure. This is sort of theory at this time. I will mention the term excipients is not what a preservative is. As you know, you probably have heard that the Pfizer and Moderna vaccine do not have a preservative in it. That's why when you open the vial, you have 6 hours to use it, or you lose it. There's no preservative in it. Excipients are additives that stabilize the vaccine. All right, so that's what an excipient is compared to a preservative. One other thing that's been coming along, you'll hear people having COVID arm, which has been reported more commonly with the Moderna vaccine. It is a harmless reaction that shows up a number of days later. People say they get this itchy rash on their arms. There's pictures all over the internet. These are benign. This is unlikely to be, if you look at the old Gell and Coombs classifications once before, this is unlikely to be a true type 1 allergic reaction, which happens almost immediately, obviously. No one's really certain if it's a type 2, 3, 4, or is this just an idiopathic reaction? But you will see this. This does not need antibiotics. I know you look at that arm and say, oh my God, that needs an antibiotic, but the patient is not febrile. This does not need antibiotics. It will just go away on its own. If it's itchy, you can try a little Benadryl. That's all you need to do. All right, that's the mRNA vaccines. I want to go quickly to the DNA vaccines. And when it comes to the DNA vaccines, we know there's the two of them, the Oxford AstraZeneca version, the J&J. What they did, and I have here up here first the Oxford AstraZeneca one, is they took a adenovirus from a chimpanzee adenovirus. And what they did with this adenovirus is they took the DNA inside that adenovirus and they took out its replicating ability, and instead they put in the DNA that instructs our cells to make spike protein. So this chimp adenovirus gets injected into you, and it instead goes into the nucleus, where the nucleus reads the DNA, and it creates the RNA. The RNA goes shooting off to the ribosome. The ribosome then shoots out spike protein. Spike protein then creates our antibodies. Ba-boom, there we are. We're back in the same spot, which is great. We got antibodies to the spike protein once again. The J&J vaccine that we'll talk about used a human adenovirus. Okay? That was the only difference between these two company vaccines. The AstraZeneca Oxford data was published in The Lancet earlier this year. It is very, very confusing. There's been a lot of discussion about how they went about their trial. But I'll try to jump to the end, and you'll see why I have to just give you a little details about their trial. They obviously, just like the Pfizer and Moderna folks, looked at subsequent disease. And what they also did, which is very, very cool, and I'll come back to this, is that they, unlike the Pfizer and Moderna people, they took their volunteers and every week they said, we're going to do nasal and throat swabs on you to see if you're actually even carrying or harboring coronavirus, which is really cool. And I'm going to get to some of those results later when we come to the question of transmission. And what they did in their trial, and this part, as I say, it's very confusing. They did 4 different trials. They sort of combined them up. you know, they were initially all designed, 3 of the trials were designed to be a single dose, and ultimately they became 2 doses. And then somebody may have heard that in the UK volunteers, there was a goof up that they were supposed to get full dose, but then a number of them got half of the dose initially and then got full dose later. And so you can see it's a bit confusing. I'll jump to the chase. Jumping to the chase is if you look at the folks they reported who got here low dose initially and then standard dose and then follow them out there 2 months later, they developed a 90% efficacy. And when you compared the standard dose to standard dose, it was 62%. You put them all together, it was 66%. That's literally what the bottom line was, 66% vaccine efficacy. But again, just like the Pfizer Moderna folks, there was no hospitalizations in any of the groups compared to 15 in the control group. So it, like the mRNA vaccines, appears to really decrease or diminish the possibility of severe disease. And that's really what we want. People getting hospitalized, getting sick, ill, and dying. Some of you may have heard that early in January, because of the bad outbreak in the UK, there was a decision by the health ministers there to delay that second dose of the Oxford Zenica vaccine that they were using because they wanted to just get lots of first doses in everybody, believing that first dose would at least give you some immunity and start driving down the outbreak that they had. In a follow-up study that was still in preprint form for the Lancet, it was published earlier this month, additional data came out from the trial where they looked at, and I'm going to just cut to the 2 highlights down below. They found that if you did delay, that first dose still did not decrease your initial antibody results. So your antibodies were good. And actually, if you delayed and gave the second dose later, you actually had a booster effect, an improved, even better effect if you went routinely at the 28-day mark. So this seems like it may be a potential strategy, and you may have heard some of the talking heads on TV saying maybe we should do this. Dr. Osterhout has been sort of in that camp, and Dr. Fauci has been very much in the camp of no, we must stay on schedule. So that's where some of this debate is coming along. Last, the J&J. Everybody's excited about the J&J. We first got a glimpse of its results about a month ago on the press release from J&J. As you heard today, the vaccine goes to the FDA Advisory Committee. The FDA released their summary of the J&J results on Wednesday. They typically do 2 days before the Advisory Committee. It's a 62-page brief that I've gone through, and it says the following, and that's what's being presented today. It says the following, that this is a single-dose vaccine, as you know. They looked at, they used it in the USA, they used it in Latin America, and they used it in South Africa. And the importance about that to note is that by using it in South Africa, you know there is the variant that's currently raging in South Africa known as B1315, and 95% of the those infected at the time of this study were infected with this variant. So it gives us a clue as to how this may or may not size up against the variants. All right, so what they found was, again, combining it all together. Their endpoint, again, you have to look at, each of the studies used a little bit different endpoint. Some of it used severe disease, some of it used moderate disease, some said even mild disease. So just in moderate to severe disease, seem to have very good protection here in the USA, 72%, 66%, 57% in South Africa. But again, when it came to severe and critical disease and hospitalizations, in particular hospitalizations, again, no noted hospitalizations or death, which is really, really encouraging. Now, I do want to make one point, and if you even look back at the Pfizer Moderna vaccine trials, those who got placebo, okay, even those who got placebo was very, very low. In fact, the death rate in the Pfizer Moderna placebo arm was only 1 patient. In this arm, there was only 6 patients who died in the placebo group. So when it comes to hospitalizations and death, that's why you get a 95% confidence interval that's huge. Because even on the placebo side, not as many, get severely hospitalized and die. And I make this point because we're going to hear, as each of these trials were 30,000 and 40,000. When we start giving this to millions and millions and millions and millions and millions of people, there will be those patients, some, hopefully not many, and my sense is, based on all this data, that a few will still require hospitalization and or die. And so that 100% over time, who knows what the number will be? 90-something% or upper 80s%. No one really knows. But even then, here's the disclaimer and the important point. Even if it's not 100%, if you decrease hospitalization and death by 90% or 85%, that's awesome. That is great. So this is the take-home message we have to continue to push to our patients and to the vaccine hesitancy groups, that this saves lives in general, as well as hospitalizations. All right, last, I'm going to try to get this through quickly and then talk about the variants. But a couple other notes. Novavax is coming along with their stuff. They've only got a press release out at this point in time. Again, their endpoint, again, now is a little different. They included mild, moderate, and severe disease, as I told you. And again, the results were very, very encouraging, especially since over 50% of the patients in their trial, those who got infected, were infected with the B.1.1.7, which is known as the UK variant. All right, so let's move on. This is the summary slide. If you need a summary slide of all of the ones I just put in there, and I even put in the Sputnik one, actually, which is also is being used in Russia, and its results have been also very good. So I'll leave it there. Again, the biggest part of this is the right-hand side, that hospitalization and death numbers. There is also the inactivated viruses. As I told you, there's being used now in China and India. I don't have any data on that, so I'm not going to say much about that. And as we know, there's at least 50 more vaccines in development. There's lots of unanswered questions. Will you need a booster? If so, when? Don't know. If I got a booster, if I got Pfizer first time, can I get Moderna the second time? Can I get this one? Can I get it? I don't have answers to that. We don't know if these are all interchangeable, immunocompromised patients. What about children? A lot of discussion there, of course. Each of these current vaccines that we have are licensed, have gotten EUA approval for 18 and older. Pfizer has completed their phase 3 trial in some 2,200 children down to 12. Moderna is doing their trial down to age 12. It's expected that they will continue additional trials for children down to age 6, but not beyond that, likely. That's the word on the street anyway, from the experts. What about pregnant patients? The CDC says to women on their website, yeah, go talk to your healthcare provider. That means us. So what are we supposed to say when they arrive? ACOG has said the following. I like this lukewarm recommendation that the vaccine should not be withheld from pregnant individuals. That's not like an overwhelming endorsement. I wish they said, yeah, you should go get it. In my mind, the way I think we should, way I'm going to respond to women, and actually I've had one of our colleagues come up and ask us this question. This is my response. If you do not get the vaccine and you get COVID infection, you have a 3-time increased risk of being admitted to the unit, ICU, 3 times an increased risk of being intubated, 70% increase in death, and you increase your risk of preterm delivery versus getting a sore arm and, oh, well, I've heard this on the internet. There is this internet rumor out there that it will cause infertility, that somehow that these antibodies interfere with something in the woman's placenta. That is completely bunk. We have to debunk that one. So just be aware of all these rumors out on the internet. And in my mind at this point in time, this is not a live virus. You know, you can't give live virus vaccines to pregnant women. Got it. But you certainly can do this. And indeed, Pfizer is now doing their drug trial on pregnant women. They're giving it during pregnancy, 24th week to 34th week of pregnancy, which the idea is that this is the perfect time to create antibodies and to give passive immunity to their baby also. It's the same sort of strategy you do with women now with Tdap. We give the women their Tdap vaccine weeks 26 to 37. So same idea. All right. Will the vaccine decrease transmission to others? This is the $64,000 question. So let me go through what most people are talking about, thinking about the strategies and discussion at this point. First off, I want to make this point, and I've said this before. This vaccine does not provide sterilizing immunity. In other words, just because of the vaccine, you still can get coronavirus in your nose and throat. You can get it there. Now, the question is, if you get it in your nose and throat, can you pass it on to others? That's what we're talking about. The theoretical or biologic reasons why the vaccine may decrease transmission is that we have IgG antibodies that penetrate our nasal mucosa. So you see it, there goes the IgG. We also have, the vaccines also elicited an IgA response. We know that monoclonal antibodies will improve viral clearance from the airways. And they actually did these challenge trials in macaque animals where they vaccinated them, and some of them, and then some got placebo. And what they then did is they challenged them. They actually gave each of them coronavirus. And then they got swab and sputum samples from these rhesus macaques and found that there was little to no live virus who got the monkeys who got the vaccine. All right, so that's the indirect evidence. What can we pick up from the trials that we know right now? So I've already told you about this, the Oxford Zenica trial, which I said was really, really cool in regards that every week they swabbed, or the patients, the volunteers themselves self-swabbed their nose and throats. And what they found is that there was approximately a 50% decrease after they got their 2 doses, a 50% decrease in the amount of patients having positive PCR results on the nasal and throat swabs. That's pretty encouraging. Also, this came out just earlier this month. This is a preprint coming out from New England Journal that looked at the Moderna trial. And they're buried in the supplement section on table 18. They also did the following. When patients came back at day 28, or I shouldn't say patients, but the subjects came back at day 28 to get their second vaccine, they swabbed them. And based just on the 1 shot, now 28 days later, they swabbed to see who might have asymptomatic disease. The placebo group, you see there's 39. Those who got the mRNA vaccine, the Moderna vaccine, that was decreased by about 60%. Actually, 15 of them actually had positive in their nose, but that's a dramatic decrease from the placebo group. Now, again, the $64,000 question that we just don't know yet is, was these 15, was this live virus or not? That we don't know. We also don't know from this paper, and it's not been reported, you can sometimes guess if the patient is, or the subject here, could transmit based on the CT values. And we don't have the CT values on these PCRs. So this is all encouraging, but everybody has been very, very, very cautious. And I will also say these exact cautious words, that vaccine may, capital letters, may decrease transmission, but we're not 100% sold on that yet. Therefore, ergo, we must, and everybody who has been vaccinated must still wear mask, hand wash, social distancing, especially when they're maybe in contact with us, with our patients, of course, and those who have not been immunized. All right, so that's the word there. All right, now the last 64,000 question, and the elephant in the room is, what about the variants? Will these provide protection against the variants? I'm going to try to move on. When it comes to variants, any of the variants, when it comes to these viruses, you have to ask, what can the variants do? If they do nothing, well, don't worry about it. That's great. But what if the variants, can they cause increased transmission? Can they increase severe disease? Can they evade detection? Do they evade our ability to treat? Do they evade vaccine-induced immunity? So these are the important questions when you talk about variants. These are the questions you want to kind of answer. And the variants that we're most concerned about in this 30,000 plus amino acid single-strand RNA virus is those variants that affect the spike protein, in particular, the receptor binding domains. This has been described as the soft underbelly of the virus. This is where our antibodies attack. And the receptor binding domain is very important that we have good effective antibodies that attach here, because it's the receptor binding domain that attaches to our ACE2 receptors. And that's part of the, if you look at the right-hand side, if you want to consider that the flowering part of the bouquet, also known as the S1 part, what that does is that attaches the ACE2. It then sort of folds itself down, and actually, ultimately, that S1 part gets cleaved off and allows the S2 part to sort of have the cell membranes of the virus and our cell membranes merge, and voila, the virus is into our cells. So we're worried about any mutations that occur at the receptor binding domain. All right. So when we look at the variants of concern, when you look at this history of the variants, when you look at the original wild type SARS-CoV-2, by March, we were well aware that it had already mutated to what is known as D614G mutation, and this is the mutation that's swept worldwide. That's what we're plagued with, this mutation now. And what it was a mutation of the aspartic acid at the 614th amino acid of that 1,273 amino acids of the spike protein, and it was replaced with glycine. And for those of you who wonder what all the numbers were, the D stands for aspartic acid. The 614 was that location, and it was replaced with G, glycine. There you go. That's what that all means. Subsequently, the next variant of concern that we all heard about was over the summer, which was the variant that involved the Y453F. This is the ones that we gave to minks, or the minks then developed this, and then the concern was the minks were going to give it back to us. So this is where in Denmark they end up culling all the minks. And now we're very familiar with the B117, which was originally described in the UK, in the Kent region of England, and then around London. It really went wild. What concerned scientists is that it had 17 mutations all at one time. 8 of them involving the spike protein, and most importantly, the mutation that occurred in the receptor binding domain known as N501Y. And the problem with the mutation at N501Y is the following. It resulted in improved affinity, of improved binding at the receptor binding site to our ACE2 receptors. It was a better binder. All right. And this is what happens, or we know what happened in the UK. In early January, they were besieged by this and resulted in their lockdown. So there does appear to be, based on epidemiologic data, we've heard that there's, it appears to be increased transmission with this variant, somewhere in the range, I've heard 35 to 70. Does it increase the severity of disease? And this appears to be a yes. This is a report that was presented to the UK Health Ministry earlier this month. 4 different reports from throughout the UK that did suggest that there is increased severity of disease associated with this variant. That's a problem. The next problem, or potential problem, does it evade natural or vaccine-induced immunity? So in other words, are vaccines going to work against this? The answer to that question appears to be, our vaccines continue to work against this. It doesn't evade vaccine-induced immunity. That's good news. That's why I put in green. You know, this appears to be the case. Where does that come from? It comes from in vitro studies. This was published as a preprint in New England Journal just a week ago. They did both the Pfizer and the Moderna. This is the Moderna data I point up here that shows there's no diminution in antibody response to the B117 compared to what has been floating around the D614G variant. So hopeful news there. Hopeful because, oh boy, this B117 is going to be a problem for us here in the States. It is spreading quickly. It is doubling every 10 days in the United States at this point right in time. The hotbed right now is Florida, although it's been seen in a number of states at this point. This is the CDC modeling of what they're very, very concerned about, that by mid to late March, that 50% of all the coronavirus strains causing illness in the United States will be due to the B117. And what you can see on the right-hand side is that what we're experiencing right now is everybody's all happy right now. The numbers are going down currently here in February. That's really, you know, exciting. Everybody's happy. Life seems to be just a little bit better right now, and we're hoping that that number keeps going down. And then, boom, what happens when this strain takes over in the United States? The concern is, because it has increased transmissibility, that the numbers are going to start going up again. That's the concern, and has led many people, including Dr. Osterhout, to say the following, and I quoted him: "We're in the eye of the hurricane." In other words, we may be in this period where things are feeling a little bit better, but the backlash may be just as bad. So I hope to God and hope that he's wrong, his predictions are wrong, but this is the concern of the CDC at this point. The other mutation to be concerned about is known as B1351, which was initially identified in South Africa. It has a total of 10 mutations, but this concern is that it has 3 mutations in the receptor binding domain. It has the same one that was seen in originally discovered in the UK and N501Y, but it has 2 more. And the one that's really worrisome is the E484K. And to give you sort of a representative sample of what this all means, is to put this into your head. These are some slides from a very bright immunologist who explained this really beautifully by the name of Shane Crotty from San Diego, who's done a lot of work in this area. And he uses this analogy, so I'll use this analogy and give him credit if I may. So the receptor binding protein here in the S1 portion of the spike protein, he likes to describe as like a shoe. And our antibodies attach to both the top, the side, and the inside and the outside of the shoe. Okay. And what happens is that, well, if you lose, if one of the receptor binding domains is lost, as in the one that we call the UK variant, you can still bind to a number of the other receptor binding domains. But when you start losing 3 of those receptor binding domains, now our antibodies, if they're trying to, for example, pick up that shoe, it's just not going to attach well. And so this is the concern regarding this variant. And additionally, the E484 mutation also has improved affinity to the ACE2 receptor. So what we're seeing is that this virus is just going through improved viral fitness. It's making itself hardier, stronger, better, which is the natural evolution of viruses. And this is the concern here. All right. Now, the $64,000 question: will our current vaccines protect us against this new variant with the 3 mutations? And the concern is, again, in vitro studies, this is in vitro, there does appear to be a diminution of our antibody responses to this new variant. The amount of diminution is estimated to be 2 to 6-fold time a response. That's the general word on the street. There's also a variant known as P1 that was uncovered in Brazil that is very similar to the one discovered in South Africa. It has 3 mutations in the receptor binding location, including the E484K. That's a problem. To put these 2 in context, why I'm worried about these 2 and others are worried about these 2 is that it does, as I point out here, may escape our antibody that we've generated, the antibodies we've generated. Now, Dr. Crotty does point out the following, that we do have other defense mechanisms, namely our T cells and our B memory cells, and these, he believes, will provide us some sort of protection. To what degree, we don't know. But the other bit of, I'll call it bad news when it comes to these 2 variants is that the monoclonal antibodies that have been developed by Lilly and Regeneron that are now being used, we cannot use against these 2 variants, because those monoclonal antibodies were designed against the receptor binding domains of the, I'll call it the main strain, and would work against the B117 UK strain. So, but it will not work against these 2 variants. That's a bummer. Last, I want to go very quickly so I leave time for questions. There's also something known as the California strain that has a mutation, as I note. This seems to be rising also in a recent sample in the Mission area of San Francisco. This now accounts for 53% of all the coronavirus infections there. And then, I don't know if any of you caught this. This came out late Wednesday night, early Thursday morning. The New York Times broke this story. Others picked up on it. And the preprint came out yesterday that there's a new coronavirus variant spreading in the New York City region. This is the preprint that I tried to get through last night. And it's called B15526 that has, the E484K mutation of the receptor binding domain, and has been seen in up to 12% of a recent Columbia University sample. So I'm going to leave with that sort of bad news. What are we going to do about this? These variants of concern. Dr. Rochelle Walensky, who's now head of the CDC, her and her colleagues published this and have been out about campaigning. What are we to do? And it's mitigation strategies, mitigation strategies, mitigation strategies. At this time, vaccination, 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 and continue to mask wear to drive this down. Because if we can decrease the overall amount of virus circulating, we can decrease the amount of developing variants. It's simple math. I mean, if there's more virus around, more chance for it to mutate. That's just, simple math. And also, as I've pointed out here, strongly advise against non-essential travel, which I guess our senator from Texas didn't get the memo. I do want to point one thing out also, however, about non-essential travel. I think a lot of us may have got a giggle or shook our heads and was incredulous about what Senator Cruz did under the circumstances. I will make mention, and this is my last point, because this is my last slide, is that as the CDC is suggested in that graph that I showed you, that after mid-March, things may indeed ramp up. And what happens in early April? Early April is spring break. All right. So some of us have college-age students at home. Some of us have high school students. Everybody for the last year, I completely get it. I completely get it. We're tired. There's fatigue. Got it. I completely understand that. And we want to go on vacation. We got to get out of here. It's spring break. Look, the numbers are down. Look, it's time to go. I can only re-emphasize what the CDC and Dr. Walensky is saying, especially at that very vulnerable time in early April, that we're going to advise against non-essential travel. And I think for those of us who laughed at Senator Cruz for his indiscretion, and then we decide that we have to go to Florida, I think the hypocrisy there will be evident. So I just throw that out there. I don't mean to be a downer for anybody's future plans, but I think if we can get through this next couple of months, all those experts I showed you at the beginning say we can make it to the end, not the literal end, but a much better situation. So I'm going to leave you there, and I want to say thank you, and I hope I'll have time for some questions and answers. So, Carolyn, I don't know if you want to jump in.
Sure.
Jump in.
Wow, thank you so much. Oh my goodness. Yes, a lot to digest, and we still are in this period of wait and see, and keep those masks on, and protect yourself and your family. And get your vaccine if you haven't had a chance yet. So thank you. I see hands clapping. That's wonderful. So let's start with some questions.
Hi,
Do you have some of the chat box, or do you have someone that has unmuted their phone?
I did, if
Hi,
it's
this
okay.
is Dean. Is that
Okay.
Peter?
Peter Weinberg, go for it.
Okay. First, Bob, excellent presentation as always, but you do not set a great example. I do not see you wearing a mask.
I am in my office closed.
Is there a mask on the door?
There's a sign on my door, no entry, by the way.
But I do want to ask a question. It's an excellent presentation, but going back to the AstraZeneca Oxford vaccine, in the data, I thought I saw that those who got a decreased first dose ultimately had improved protection compared to those who got standard. Did I miss that or not?
No, I think I mentioned that. In fact, it's on the slide. Those who got half dose,
Right,
followed by full dose, when you compared those to full dose versus full dose, they actually appeared to do better.
Right, no, I understand. The question is, the speculation is there is there any basis for that? Is it something that we're missing, and perhaps it's a better regimen to do?
Yeah, no, there is speculation, and I don't want to speculate. I've heard the speculation, and I don't know if I can really, because I'm not an immunologist, but that this was sort of a primer dose, and then you got your booster, and kaboom. I don't have a real good answer, and I will defer really to all the other speculators and really smart immunologists.
Good, thank you. Excellent.
Thank you. Bob, one of the This Week in Virals, they discussed it, and they think that it was that the full dose, you had too much of an immune response because it was similar to previous viruses, so you didn't actually make any memory to it because you pretty much wiped it out initially. The half dose didn't cause enough to wipe it out, so you actually could make some memory to it.
Oh, cool. I didn't catch that part. Yeah. Cool. Very cool.
Thank you, Bob.
Yeah.
Hi, Bob. Dean Lemary. Hi. That was fantastic. Comment and a pondering question. The comment when you talked about Moderna early on, you were right. The Chinese released the genetic material, the genetic code, whatever, in January, and Moderna in 23 days in February had their vaccine made. The pondering to me, and I don't know the answer to this, I'm just curious on thoughts. You know, I think it was mid-December when we had the UK variant case in the jewelry store in Saratoga, and several people were positive. And then a few weeks later, there was a case in Warrensburg related that when they looked at it all, there was a tie back to the jewelry store. So now we're a few months out, and I was waiting for an explosion to happen, and it hasn't, at least not in our area. And I don't know if you have thoughts on that. I don't really understand why, if this thing is so transmissible, we didn't get blown up with it.
The only thing I can really say, Dean, is that you know, if it's doubling, quote, every 10 days, so that's mid-February, and I'm not a mathematician, but just doing some quick math on the top of my head. If we're starting with a very low number, and then you keep doubling in 10 days, it may take some time to really explode. I think that's what the mathematical graphs from the CDC that I put up there sort of suggested, that this, you know, it will take time, but will explode. And I just don't know if, you know, when this was first described here in our region, has been long enough for it to double number of times over.
That I have is testing enough. So we're flying a little bit blind if we're not testing enough of our specimens on their genomes. So
Right.
It may be much more around than we realize.
So, yeah, it's true.
Marty Farber, that was really great. I really enjoyed that. And I second your notation of TWIV. If I had thought about it, I'd be wearing my TWIV mask and TWIV t-shirt. I had a question on the data that you presented with the J&J. It said that there was an 85% reduction in severe and critical disease, but 100% in hospitalization or death. Wouldn't severe and critical disease be subsumed in hospitalization or death? I don't understand why, you know,
Yeah.
it would have been the other way around, I would think.
Now, yeah, what happened was, and I looked into those 62 pages, and it's how they decided to define severe. And severe you had to have two of, I don't have it right in front of me, like 10 or 12 different symptoms. And, you know, when I put it together, one of them was headache and one of them was high fever. Well, heck, headache and high fever, that happens in even just mild disease. So it's really how they define severe, which, you know, really to me in certain situations could have been more moderate. And I think that's, that's, if you look into that, how their definitions were, I think that's how that split out.
So people who had severe and critical disease weren't hospitalized.
Yeah. Oh, some of them were not hospitalized. Exactly.
All of them were hospitalized, or hospitalization wouldn't have been 100%.
I'm sorry. I got to go back. Hold on. Let me see if I can. We're playing a numbers game. I'm trying to. Let me see where I am here. But the point is, again, I think, Marty, when I looked at this, it's, how they defined it. And I do apologize. I don't have the paper right in front of me to give exact definitions.
Thanks.
All right, no problem.
This is Dr. Yap here. Let me try and see if I can answer that question a bit, because I do watch TWIF too, and Paul Offit, and I thought I saw him mentioning something that in the test in South Africa, the patients who receive the vaccine, some of them do get a reinfection, but it's mild rather than moderate or severe. And in some of those places, there's not many hospital beds, so even if you have moderate disease, you probably won't get admitted to the hospitals.
Thank you. Thank you. Any other questions? Anything in the chat, Emily?
Yeah, I'd like to ask a question. I understand that once you're past 2 weeks, second immunization, second vaccination, you're safe to meet with other people that are in the same category and socialize with them. But are you required still to use your double masking or masking when doing that?
I'm sorry. If you, let me. I think I can answer it on TWIV. Dr. Berger from down in New York City, an infectious disease expert, I think your question that you're asking is, he said he feels comfortable with if someone's fully immunized, 14 days after their second, meeting with someone else who is in the same situation, does not feel that they can take their masks off in that situation. That's what he said. He gave the analogy that Passover is coming up, and he wants to have a Seder dinner with his family, mother, father, kids, etc. His parents are fully immunized. He's fully immunized, so he feels comfortable sitting with his parents. The children, however, are not immunized. And what he's planning, and I'm just going by what his plan expert is, and I don't think this is any formal recommendation, but his feeling is that for them to now sit at the Seder table, that they obviously need to be asymptomatic, but also need a test. And he plans to get his kids tested before the Seder dinner. Again, I don't think there's any formal recommendations on that. I'm just giving you one, quote, expert's opinion. And I don't know if that answered your question specifically.
I guess it's as good as I'm going to get. Yeah. I was thinking more of adults, not children being involved.
Yeah. Yeah. Well, I think you could use that analogy as the children as the any unvaccinated person.
Dr. Dachs?
Yeah.
This is John Assini, and thank you so much for a wonderful talk. I didn't catch all of it, but there's one thing. Just what is your take on school reopenings? I'm reading a lot around the country, and there's this big push, and it just seems to me, especially with the variants, that it and the recommendation of non-essential, don't avoid non-essential travel, that opening up schools, I don't think we have enough data to be able to say, yeah, that's a safe thing to do. And I would just like your comment about it. Thank you.
I'll give you a comment. I don't mean to really avoid the question, Dr. Cini. I do agree with the one thing you said. I don't think there's any data we can hold our hat to and come up with anything firm. I don't even know if there's enough indirect data out there. I do know there's definite pros and cons to this. I think we've all heard the pros and cons. It really depends on, and this is all of us. If you take a very, ultra conservative approach, if you're the type of person who's risk averse and wears belts and suspenders, then I think you would say don't open. But there is the other side of the coin, that this is an issue for a generation of children, and the need to be in classrooms, especially my understanding, and I'm not an educator, believe me, that the younger children, the grade school children, are the ones that, as I understand it, do not benefit from internet learning, whereas the older high school children can manage that a little bit better. You hear my hesitancy in my voice. I'm sorry that I just can't fall down on one side or the other, because I just don't have an answer. I don't know.
I appreciate that it's an extremely difficult thing. I've read about some school districts that are even starting to say, well, we're going to decrease social distancing, or people are going to have lunches together. I mean, some schools are getting, gung-ho, and I'm kind of saying, with the data that we have, we may be just getting into the other side of the eye of the hurricane when this is happening. So that's my concern, but I appreciate your hesitancy.
Yeah.
It's a difficult call. Thank you very much.
Yeah, thank you.
I have one question. This is Dr. Yap here. From what I've been reading, most of the vaccine efficacy cases, at least for the in vitro ones, using neutralizing antibodies and not using any sort of cell-mediated immunity. Is that true?
I don't know if I followed it with Dr. Yap one more time. They're using what kind of antibody? I'm sorry.
Oh, they're testing the vaccinated patient by using neutralizing antibody tests. So basically, they're taking plasma or serum. But in virus immunity, there is this cell-mediated immunity that may be more important. So are they just doing part of the immunity test in vitro rather than doing the full spectrum?
I can only go on what so you're asking an immunology question that those slides from Shane Crotty addressed, that currently with these variants that are testing, it is in vitro studies, seeing how much neutralizing antibody remains with the newer variants. And I don't know if his lab or other labs are looking at the other components, the cell-mediated components, the T cell responses to the new variants. I can only assume they're doing that, but I've not seen any papers. He didn't report that they have data saying that there's really still good T cell response, good B memory cell response. He knows theoretically that there should be some response, but did not give any data on that.
Thank you.
Okay, anything else? Maybe we'll take one more question. Certainly, we appreciate all of you joining with us today, and please return next Friday to have us learn from Dr. Yap and discussion of musculoskeletal spine issues in adolescents. And again, please stay safe, keep wearing your masks, take care of yourself. So important. And again, thank you, Dr. Dachs. Oh, I hear the clapping. Yeah, yes. I agree.
you.
I agree.
Oh, welcome.
Dr. Dachs.
Pleasure. Pleasure. Thank you.
Okay. Good day now.
Bye now.